It's really a great pleasure that Dr. Rima Khabbaz, who is the Deputy Director for Infectious Disease and Director of the Office of Infectious Disease at the US CDC, the US Centers for Disease Control and Prevention, could make it today, so very great pleasure. Dr. Kabaz has served in leadership positions across the CDC's infectious disease activities since the early 1990s, including the position of Director of the National Center for Preparedness, Detection and Control of Infectious Disease, and Director of Epidemiologic Science in the National Center for Infectious Disease, the NCID. Her leadership role covered several of the CDC's responses to outbreaks of new and or emerging infections, including Ebola, West Nile, SARS, that is well known to many of us in this area, and monkeypox. Dr. Kabaz is a graduate of the American University of Beirut, Lebanon, with which we also happen to have a number of relations, where she obtained both her bachelor's degree in science, biology and chemistry were her majors, and her medical doctorate degree. She trained in internal medicine and completed a fellowship in infectious disease at the University of Maryland in Baltimore. In addition to her CDC position, she serves as clinical adjunct professor of medicine in infectious disease at Emory University. She has authored and co-authored more than 100 scientific articles, book chapters, and reviews. And she is a fellow of the Infectious Disease Society of America, IDSA, and a member of the American Epidemiologic Society, the American Society for Microbiology, and the Council of State and Territorial Epidemiologists. She also is a member of the Institute of Medicine's Forum on Microbial Threats. So a long list of great accomplishments and important positions. Once again, it's great to have you here.
Great, thank you very much, Holger, for that very kind introduction. In terms of, we do first have a bit of an apology, in that we had hoped that there'd be four of us up here. We learned that last Thursday that Dr. Pablo Curry wasn't able to make it this week. The presidents of Mexico will be launching this week a new national strategy on obesity and overweight and related issues. So when the president of Mexico asks his Undersecretary of Health to be there and participate in that big launch, we know where that Undersecretary of Health is going to have to be. And then last Friday we also heard that unfortunately David Butler-Jones, the Chief Public Health Officer of Canada, also wouldn't be able to join us. But as Holger mentioned, we have Dr. Kabaz from the US Centers for Disease Control and Prevention. And if you think about it from a budget perspective, we do still have 90% of the panel here. So I think we're going to make sure it'll be a great discussion. And Dr. Kabaz, thank you again very much for joining us.
Thank you.
So before I launch, I do have some questions, and we've talked that because it's two of us up here, we're going to keep it very conversational, and we'll chat about some issues. So some questions prepared, others will just naturally emerge. But before we start, I did want to ask you, Dr. Kabaz, maybe tell the audience a bit about what you do on a day-to-day and what your role in the CDC is, maybe about the Office of Infectious Diseases.
Okay, well, thank you, Stephen, and thank you, Holger, for the introduction. Can you all hear me? Okay, so a little bit about myself. I'm a physician, infectious disease trained, and I have worked in public health my whole career. And if you asked me about it when I started, I had no idea I'd be doing this. I thought I was heading to a clinical career. I was interested in infectious diseases and wanted to do that. And like so many people at CDC, it was what I thought was a transient training experience in public health, and then I would go back to public health, and here I am. I'm hesitant to say how many years, but it's been, you can count it in decades that I've been there. At CDC, I'm the Deputy Director for Infectious Diseases. We have reorganized 4 or 5 years ago. So this position and the Office of Infectious Diseases pretty much houses all our infectious disease programs. We have 3 large centers, one focused on immunization and respiratory diseases, and certainly influenza, one major pandemic concern is there, and other respiratory, viral, and bacterial illnesses. And then I have a center for HIV, hepatitis, STD, and TB prevention that focus on more of the chronic diseases and special populations. And then we have a center for emerging and zoonotic infectious diseases, the rest of the infectious disease gamut, the zoonotic diseases, healthcare-associated infections, and a broad portfolio of work. And so I'm fortunate that I have great staff. One of the best things about my job is the people I work with at CDC, both in terms of the staff down to the people who really do the job, get out there and run the programs and do the field investigations and the surveillance, to up the chain, the leaders, the center directors that I work with. So what I do on a day-to-day basis, in fact, I have 2 kids, and at one point they've asked me the question growing up, what do you do? And I said, well, I go to meetings, and I go to meetings, and I talk, and I'm behind the computer, and they said, oh, that doesn't sound too exciting. A lot of, but the fact that they both ended up in medicine and doing getting public health training as well, maybe is a testimony that it's not that boring, and I think they saw the passion and the excitement and about the impact of the work that I do.
So one thing is clear, that you are eminently qualified to answer my next question, which is, in your mind, what is the single greatest challenge the world faces in preparing for the next pandemic?
And you wanted one.
Only one, single greatest challenge.
Single one, I would say complacency. We have collectively as a society and as a global, we have a short memory, very short memory. Maybe that's colored by living where I live, but I think it's true everywhere. We forget, and so it's complacency and a real grasp that these things are going to occur. I mean, they're predictable surprises that we're going to have pandemic, and doesn't mean that it's going to be exactly what you expected and the same one that maybe you had a few years back or a decade. So a complacency and an expectation that, okay, it's not going to happen, but then if it's going to happen, it's going to be exactly the same as what happened before. Now, having said that, I think we have come a long way in the past 10 years. All of the work on H5N1, the avian influenza virus, concern of a pandemic that has slowly been spreading and morphing around the world, have really, I think, has really mobilized us to be prepared and pay attention. And I think there's been a lot of efforts on planning and exercising and then lessons learned. Then we had SARS, of course, and you all experienced it firsthand. We got involved, but it wasn't like what you experienced. And so there's been a lot that has happened the past 10 years to get us better prepared and maybe a bit less complacent. Then we had H1N1, and people said, oh, it's not what we expected exactly. But I think we did relatively okay. But I think in the long term, we forget. And then there's the reality of the economic situation around the world and the fact that dollars are limited and health dollars, even though you started by saying maybe I'm 90% of the budget, but in general, all over, health dollars, very small fraction of them make to public health and to prevention. And so, it's challenging as well when you think about all that needs to happen and be in place for the next pandemic.
Yeah. And I've heard people have said that in some respects, public health is sometimes its own worst enemy, in that you talk about complacency. Some people have said that the response to H1N1, which was 2009, 2010, in many respects, this was not an Armageddon doomsday pandemic that we see in movies, Contagion, or all the various ones that have Hollywood has made for us. And so some people say, well, if that's what a pandemic is, and then we see H1N1, and of course it was terrible for those who had it, and quite a few people died, but it wasn't in the same, it wasn't like what we see in movies. To what extent do you think that might breed that complacency? Because that's a different type of complacency.
Yeah, now, you know, Stephen, we are our worst enemies. And in fact, we don't talk about what we do and what we do well. And the fact that H1N1 was not as bad, partially, I would say, probably the severity of it was not what the 1918 pandemic was. But I think, in my mind at least, clearly there are a lot of things that we did that mitigated it from being worse than it was. And that doesn't get talked about. I mean, would you agree with that? Doesn't get talked about a lot.
Yeah, no, definitely doesn't. There's a lot of, I've heard a lot of people have said that H1N1 might have been the first pandemic we faced as a global society that human intervention actually really stopped from causing enormous devastating consequences. And it was, and I've heard other people say that it was very much because of that learning and lack of complacency. We had SARS, which was terrible, and it was an event that changed public health infrastructure, certainly in Canada and around the world, but that in many respects was the perfect training for H1N1, which I've heard other people say it could be worse, but because we intervened, it wasn't.
Yeah, no, I completely agree with that, obviously. Also, I think every time we have an event, a pandemic, or a smaller outbreak of sort, we step back and say, well, did we do it right? And there's always something to learn from that response. And I think with H1N1, we've done that. We've done that at the CDC where I work and with other groups in the US, and we've done it with other countries, partners, etc. And one of the things we've seen is that we are not as good at predicting the severity of a pandemic. That is, early on as a pandemic unfolds, you need information, right, about how it is transmitting, how severe, and that information is slow to come by, and so you kind of do severity risk assessment, and sometimes you do it with H1N1, you do it with incomplete information. So I think that's one area that one can do better. So then you oversize a response or undersize your response, and so it's not perfect, but I think again I think it went fairly well considering.
So with that in mind, is there anything that keeps you up at night in terms of the world's current capacity to prepare and to respond to a pandemic?
With this question, I'm tempted to copy my boss, CDC Director Dr. Frieden, who was asked that question recently, whether he's kept up at night, and I like his answer. He said, I sleep well, which actually I sleep well as well. A function of good diet and exercise, although he probably exercises more than I do, and the comfort of the staff that we have. So having said that, I think a source of concern that I will mention is our capacity, collective capacity around the world. So we have the international health regulations. I don't know how many people in the audience are familiar with. These are the revised international health regulation that WHO passed in 2005 to basically ask that all countries, all member countries, develop some basic capacity for detecting and responding to infectious diseases, as well in it is a requirement to report public health emergency of international concern, in time, and basically to help us collectively, globally, get on top of these global health threats faster. And in 2012, assessing countries around the world, less than 20% of them reported having the needed capacity to detect. And so that has to do with laboratory capacities, having laboratories that are able to test for the pathogens of concern, and having systems to track diseases, look at what they have, and find things and report. So there's a whole list of things. So I think that's one of the things that's a big concern, because we are as strong or as weak as, I think, our weakest link, and we don't know where the next pandemic will arise, and the thought of a large number of countries not having enough capacity to deal with this means that the next one coming, if it happens to be in one of those countries, and they tend to be the under-resourced countries, then it's going to take longer to find out about it, to learn about it, and so when you don't detect these things earlier, then obviously there's a lag time in response, and so mitigating effect of that becomes harder. So that's the one thing that I would mention as of concern.
Yeah. So if only 20% of countries have the needed surveillance, detection, laboratory capacity, what does that mean then to someone, let's say, who's a deputy director of infectious diseases for US CDC and knows that only 20% of countries have that capacity, 80% don't have that capacity? You have a responsibility, in your case, to protect the American public and the world's. And then in Canada, we have an equivalent agency, the Public Health Agency of Canada, that would have a similar role to what you serve in the U.S. What does that mean then in terms of your ability to protect the citizens of your country and the world?
You know, I think we have a responsibility to responsibility, us, the U.S., you in Canada, and other, better resourced countries to step in and help build capacity in those countries that don't have the capacity. And that is, again, the basic infrastructure for detecting, the laboratories, so that they can deal with the day-to-day infectious diseases that they deal with, be it, detect new threats and respond, and also use the tools that are around to prevent diseases. I mean, we have vaccines, we have, there's a lot to do. And so I, think that it is a shared responsibility to help build that capacity that will help, countries and help us all collectively in the long run.
So it's certainly clear that there's quite a capacity challenge, and we definitely need to scale up capacity around the world, and Canada, US, but in particularly the 80% of countries where there isn't that capacity, that basic capacity that's needed. But there's other people who argue that sometimes looking at public health, which itself is already so underfunded as compared to other parts of either the sectors or even within health, public health is often the poor cousin. There's so many people who say that within public health, which is so limited, aren't pandemics getting too much of the resources within public health when there's issues like chronic diseases, obesity, diabetes, mental health challenges. And yet, many of those sectors might say pandemics are getting too many of the resources. What do you think about that?
I think the point about scarce resources and competing priorities is a good one. I would offer to say, when I think of pandemic preparedness and building capacity, I don't think of it in an abstract. And so if it was just to putting together systems that are going to be, activated when you have a big one, then I would say I completely agree. I'm talking about the basic capacity to deal with day in, day out health problems, and these include infectious diseases, having laboratories to detect them, the burden of respiratory diseases, the burden of diarrheal diseases, tuberculosis, antimicrobial resistance are real ones around the world. So not at the exclusion of, chronic diseases, but they're real, affecting people. So building capacity is the tools to deal with what you have there, and these are the same systems that then will help you respond to a pandemic. So I think of them as a continuum, and I not plans on the shelf or systems, one-time systems to activate.
In terms of building capacity internationally in those 80% of countries that don't have it, this is certainly one area where the CDC's work might overlap in terms of interests with that of, let's say, the U.S. Department of Defense. Certainly the U.S. Department of Defense has been putting a lot of money into disease surveillance in countries, seeing pandemic as a health security threat, just whereas we might see it as a public health threat. It can be easily repackaged and thought of as a security issue in need of defense intervention. Is this an opportunity for public health to seize all those defense dollars? But then if it is, or is it not? And if it is, to what extent does CDC have to then manage the challenges of CDC, which wants those dollars for public health purposes, Defense Department, which might have other strategic interests in mind? How do you manage that?
I don't think you ever think of seizing defense dollars for public health.
That doesn't happen in the US?
I don't know. Does it happen in Canada?
Well, yeah, probably not.
I think your point, though, that there are common priorities. The Department of Defense investment in health and in health security. Part of it, as I understanding from DoD colleague, is driven by protecting troops and people who are serving, and given that they're deployed around the world, then understanding the diseases and infections and dealing with them. So I think we have common ground in terms of priorities, and certainly leveraging and working together on those common priorities to enhance. And we talk about that. We say it's a global health security. I mean, we don't speak another language. That's what we're talking about for pandemics. We actually engage and where there are common priorities in terms of to give you an example, they're invested in development of new diagnostic tools and point-of-care tools that are very important. This is the next generation of diagnostics, not cultures. And so I think we have, again, in that area alone, common priorities and learning from each other and leveraging their investments so that we can, help in this domain is important.
Yeah. So we've talked a bit about building capacity at the national level, so U.S. and Canada, but also then the other 80% of countries. What about let's step up a level of governance, looking at the global regime? You've mentioned about the international health regulations, which were revised in 2005, and which is actually an international law. It's a treaty that's binding on 194 countries around the world. And this international law is very much the bedrock of our global governance of pandemics. But if you were to think about what you'd like to see changed with the current global governance arrangements, what would those changes be? Because of course, when a pandemic emerges in whatever country it emerges, part of, as you've mentioned, so much of the American or Canadian response will be dependent on how it's initially dealt with in whatever country. And so this would be one of those natural areas where every country is vulnerable based on every other country. So what can each country promise to do up front in order to protect all countries? It's a natural place. What would you like to see changed?
First of all, I think the role of WHO in global governance is crucial. I mean, it's a crucial role as a convener, as setting up expectations of standards. The IHR is a very important milestone. Now they can't police it, and there's no enforcement. Thinking back of SARS, the network that they pulled together to help us in a record time for then figuring out what the SARS was caused by was phenomenal. And I would like to see more of that, more connected networks and collaborations. It's a challenging time. They've stepped up and worked in the context of H5N1 on a document called the Pandemic Influenza Preparedness Framework that you're familiar with, and you probably can say more about it than myself. But one of the important premise of that document was the concept of being able to respect intellectual property. Countries where a pathogen is discovered. This was spurred by Indonesia and H5N1, being willing to share it with other countries and other labs so that you can get on the work of characterizing the virus and speeding up the make of seed vaccines and countermeasures. At the same time, the issues raised were difficult issues of equity and access to then the products, for the vaccines and diagnostics and countermeasures for a disease that might be occurring more in a country where it, and how do you do that and facilitate equitable access to those products. And so WHO, here's an example of where they stepped up and did this. And so this is for influenza. I think we have a challenge ahead of us collectively for other than influenza. I don't think we have a similar framework, and there are similar difficult issues that arise with sharing and sharing of specimens and pathogens.
Yeah. So you mentioned two things I want to pick up on. One was about you said that the international health regulations, that international law about pandemics, it doesn't have any strong enforcement mechanisms, which then makes it very difficult in order to ensure that every country is following its obligations. To what extent do you think an enforcement mechanism is desperately needed, or a little bit needed, or not needed at all because alternative ways? To what extent is that really a key?
I don't know. I'd like to ask you that. Yeah, you actually, from your perspective of looking into global governance and.
Yeah. Ooh, I wasn't anticipating that the question thrown back at me. But some part of the reason I asked the question is because I do research in that area. Well, yes. If we look to other regimes, so the World Trade Organization, for example, has been probably a bit more successful than the World Health Organization in terms of enforcing its agreements. At the World Trade Organization, there's a process that if there's ever a disagreement between two countries over a trade-related provision, then those two countries can, one of them can complain and bring it to a dispute resolution board, which then will adjudicate the matter. And then there's a series of enforcement mechanisms, such as raising trade barriers and such as punishments for if one doesn't follow those the ruling of the dispute resolution board. WHO doesn't have that. Under the international health regulations, it's countries that are in disagreement, such as you mentioned the example with Indonesia, where during H5N1, there was this case where Indonesia, it was spreading animals to humans within Indonesia, and Indonesia was refusing to share the virus samples with the rest of the world, who desperately wanted it in order to develop a new vaccine for it. And the reason that Indonesia said that is why would we give away this viral sample of H5N1 when someone else in a wealthier country like the US or Canada would then use that to create a new product, get a patent on it, and then Indonesians wouldn't be able to afford it anyways. So they'd be giving the virus sample to other, mostly labs or companies, to then create a product, patent it, and then not be able, Indonesians wouldn't benefit at all. So that's what that PIP framework was very much about. But the problem, it took 5 years to solve while the H5N1 was spreading, and fortunately it didn't, I don't think there wasn't much human-to-human transmission, so it never emerged into, I guess, a serious public health event. But it could have, and it took 5 years to resolve that because there was no, in my mind, because there was no dispute resolution process or strong enforcement mechanisms.
Yeah, the premise of, one of the premises of, I guess, the international health regulations and those frameworks is that we, in public health, that we share common values of, the public, the common goods and that the desired outcomes, that we have a strong, collectively global commitment towards the same outcomes. And I think that's probably true. I think, countries have, there's also the advantage of, we've come a long way to see the advantage of transparency and negative economic impact if you don't address your global threats or your threats that could become global. So I think contributes to bring more compliance but it can be challenging. It could be political wills and other reasons, and so it's. I don't have an answer.
Yeah. And of course, states often don't want enforcement mechanisms or dispute resolution mechanisms, because if states did want them, they would be in there, because states are the ones who are able to. I guess Canada and the US are both countries that generally don't want enforcement mechanisms or dispute resolution mechanisms. So it's both of our countries are there. The second thing I want to raise from what you earlier said was about WHO. The WHO, the World Health Organization, clearly has a big role in governing and in coordinating the global response to a global pandemic. But WHO is in many respects in crisis at the moment. Over the last couple of years, its budget has decreased by 1/3. Staff have been laid off across the organization. And there's efforts to reform the World Health Organization, but there's been efforts that are continually and perpetually there to reform the World Health Organization with limited success. And of course, the body, which is the UN's health agency, has had enormous success in some areas. Smallpox is often an example, and pandemics is probably a place where it does have relative strength compared to other areas, but it's still in crisis. And when we talk about, are we prepared for the next pandemic, if there's anything that would keep you up at night, is a fractured WHO, a WHO in crisis, is that something that concerns you? Or do you have any ideas?
No, I think we need a strong WHO for all the reasons that you said. Somebody once said if we didn't have WHO, we'd have to invent it. It's quite critical that they be strengthened, that they be able to do what their charge is. They have a unique role to play.
Is there anything WHO could be doing, from your perspective as Deputy Director for Infectious Diseases at CDC, is there anything that WHO could be doing better that would make your job easier?
I think they're working through some, as you said, some existential questions and trying to prioritize what they should do. And I don't think I don't think it'd be helpful for me to second guess them.
Okay. So before we go to the audience, a couple more questions. So the audience, everyone, soon it'll be your challenge to come up with the questions. I want to ask about independence. So CDC is it's the world's best public health agency, most funded, and it has over a series of decades built up a reputation such that it enjoys quite a significant degree of independence from political interference. But of course, the CDC director still reports to the Secretary of Health and is still responsible to politically motivated actors, of course. So how does a public health agency like CDC, how does CDC balance that tension between, on one hand, being scientifically independent, but on the other hand, ensuring that it's responsive to political needs, but ensuring that it's not being co-opted by those political needs?
Yeah, thanks, Stephen. That's a very good question. So CDC is obviously one of the oldest public health agency, and I think there are some, great, outstanding agencies that have come, since then, including your own Public Health Agency of Canada and others. I think that question of independence. So first of all, CDC is located in Atlanta, right? Whereas the rest of government is in Washington, D.C., including the Department of Health and Human Services, to which we're under. And I think that geographic separation, I think, give you, be it, distance a little bit and some independence. The agency has, through many years that I've been there, really taken seriously the need to be science-based and in policies and decision, evidence, bring the best evidence to the table. And, has there not been time when there was a tension between the, science evidence base and the policies? Of course there have, and these are worked out. So it's that tension is probably also healthy. Science and evidence based, but public health is inherently political as well. So I think we've been lucky to have different directors over time that have managed to walk that fine balance and in supporting the agency and the science and the evidence base at the same time, working within a department and within a system, a political system.
So then my last question before we turn over to the audience is that I see there's quite a few students in the audience, and students who are preparing their careers and maybe are interested in public health, but they face a very different public health, a very different risks and threats in the world than maybe those who are, and maybe then the director of the CDC would have faced when he graduated from school. And so it's in some respects maybe different skills, different focuses, different modalities that need to be pursued in learning and such. And so you mentioned health is political, health is technical, and we need political and technical people. Do you have any thoughts on what the future of public health will be, and what sort of skills and training today's students need in order to be future leaders in that new environment?
Yeah, well, first of all, public health is very, very exciting and a great career choice. For those of you in the audience who are kind of wondering, it is. I mean, it's very compelling in terms of the work that you do, in terms of the making a difference, which I know, students always want to do that. I mean, the opportunity for impact and impact on a population level is just huge. And the other thing I would say is that this is a very exciting time for public health. The interest in global health, I think, is unprecedented. Yes, WHO has its own challenge, and there are some resource constraints, but I don't think we had seen that many private groups really get interested in public health and number of initiatives happening. So it's great. In terms of tools and new tools, I'd mention two. Area of informatics is very, very important. We have systems for tracking disease that need to be retooled, and that are being retooled in some areas faster than other. But we need to, in public health, needs to enter the 21st century in terms of the use of informatics and better than we have. The potential is obvious for faster, more efficient information sharing. So that's one. And the others is biology. I mean, we have a revolution occurring in the life sciences ushered by the four-letter alphabet, the genomics, and the potential for our laboratories as well to retool in terms of those genomic-based technologies. And there's a new field, probably students know more about it than I do, bioinformatics. So we have to, when you do this genomic laboratory, rapid genomic sequencing generates tons of information about pathogens. Now, I'm not even talking about humans. And to be able to analyze it and put those pieces of the puzzle together to figure out what you have requires experts at the interface of, it's a high computer science and biology information. And this skill is in short supply and huge need, not just in public health, even in research and other part. So I think these are two skills and areas, like you said, that certainly we did not have when some of our workforce, and we need to actually. We have been talking about retraining some of our current workforce to acquire these tools so that we can improve what we do. So certainly for students, I would say pay attention to these areas and as much as you can learn and skills and tools, I think they're going to be part of the future of public health careers.
Right. So we'll now turn it over to the audience to ask the really tough questions. I'm not supposed to say that. So ask the questions. We have there's a couple of students who volunteered to help bring microphones to those who have questions. So if you have a question, just if you put up your hands, I'll point to you, and someone will rush up the microphone. To that person, and then if you can speak into the microphone, that would be great. First, maybe just say if you can introduce yourself, that'd be great. That's in line with the conversational tone we're trying to foster here.
Hi there. Good evening. My name is Blair. I'm a medical student here at McMaster, and I spent the last decade working as a paramedic. And the very first question Dr. Hoffman asked was about the greatest challenge that you face, and you said complacency. And I've seen sort of the waning of vigilance that comes after an epidemic amongst frontline healthcare providers. And I'm wondering, what does the future hold for helping frontline healthcare providers identify these types of patients in the future, either at triage or at the bedside? Are there new technologies, new screening tools that are on the horizon?
So what's on the horizon?
New technology. So the question is, what are new technologies on the horizon to help frontline providers screen and identify for a particular? Yeah. Some of the. I mentioned point of care tests. I think that may be part of what's on the horizon in terms of being able to quickly diagnose. And I couldn't tell you how big a horizon or shorter, but there's a lot of work going on in those areas. That's one that I would mention. There's probably other things that none come to mind.
There's certainly a lot of discussion about changing the social environments in which frontline workers will have to be working in order to ensure that they can perform the job as best as they can, which I work more on the social side of things. There's a lot of talk that the recent experience with SARS and H1N1 have forced us to think through some really complicated challenges about the way we organize hospitals, the way we organize, the way, for example, paramedics might transfer over patients, or the ethical issues, the legal issues, all those issues that are changing the environments in which frontline workers are working. That's another one.
I would add one, and it's not relevant to frontline providers, is personal protective equipment. We don't have all the answers, but that's an area of an important area of research to figure out the best personal protective equipment for frontline providers.
Great, thank you. Great. Do we have a microphone? Great.
Hi, my name's Sarah. I'm a fourth-year arts and science student, and I took a course with Stephen last term that was focused on pandemics. And I was just wondering what your thoughts were on using EHealth and maybe MHealth as well to try to better identify the severity and the transmissibility of diseases, to try to maybe also to battle the complacency battle so that there's a more appropriate response for each disease as it comes up.
Yeah, so what's the the potential for MHealth, EHealth in order to make a better response?
I think it's a good question, and they have a role. I think I think they have a role in the armamentarium of gathering data and figuring out what's going on. Yeah, definitely.
Yeah. Is there a lot of work at the CDC about those? That I guess I know globally, on the global health side, there's a lot of talk about MHealth, which would be using cell phones. More people have cell phones than have access to the internet, and I guess my understanding is they've recently, over half the world now has a cell phone, if not more. Okay, heads are nodding, so that means I got that statistic right. So it's the penetration of cell phones is so great that increasingly we're seeing in global health discussions about using cell phones in order to ensure we have a better response. So, is there a lot of talk about that?
Yeah, there are projects underway looking at cell phones, both in terms of gathering information, people reporting what they see or experience, as well as for putting out information, prevention information, reaching out, through MHealth.
Great. Any questions, Nicole?
Thank you very much. Hello, Dr. Kabaz. It's great to hear your perspective, especially as a representative of the CDC here, one of the biggest players in pandemic preparedness. I'm a fourth-year health sciences student at McMaster, and I also took the course with Sarah under Stephen's guide, introducing us to the conflicts of pandemics. And my question comes from the point of view of the public, because pandemics are one of the public health topics that is so relevant for public awareness and for the general public to be interested in the work of the CDC, especially since it has such a matter of emergency when a pandemic is happening. And my question has to do with media and social media. And I don't know if the CDC is able to put any regulations in a time of pandemic or epidemic within their jurisdiction to regulate what goes on, what information is being shared by the media and by social media. I don't know if this is a controversial question to ask, especially in the States, and there's been a lot of talk about infringing on an individual's rights and freedoms by monitoring social media and other communicative mediums, but I want to know if in a time of pandemic, is that different, and is that happening?
Yeah, no, thank you for the question. I'm, not aware and don't know that there are any opportunities to regulate or interest in regulating media or social media. I can tell you that there's a lot of talk and actually move to actually use the media and social media for putting out credible information, and we do this increasingly so in regular times, and would be doing so in pandemics, and we have used it in outbreaks, and it's actually been quite successful. There's also some, when you say monitoring, I'm trying to think, there are some social media sites that actually do that. And so looking at it and see, well, how can you use them to track disease and learn from them in terms of patterns. But
there's the Google flu tracker.
The Google flu tracker, and there's some other similar programs, yeah. So both in terms of better and more smartly use the media and social media to reach segments of population with information and in terms of tracking disease. But did I get your question right in terms of regulating media, what goes out there?
Maybe I can paraphrase. It does seem that Nicole's mentioning this issue that there's a lot of misinformation out there. Is that's you're going at the misinformation?
Yes, it's particularly with fear-mongering and misinformation being shared by non-health experts regarding a health topic.
Yeah, Nicole, that's a huge challenge. One that challenges nothing that we can do much about that I'm aware of. If there are ideas, I'd love to hear them, but it's a challenge. And the public is challenged because they don't know what, again, it's hard to know what is a credible, reputable site or what is putting out information, misleading and incorrect information. And
certainly we saw that that was very much at the center of, in the movie Contagion, where we saw what's different factors, the misinformation that was being spread and the extent, the damage that caused. And of course, We are hardwired in many respects in order to think of people who might be successful in one area. They make a comment about health, and we instantly see them as being maybe successful in another area. I've done some research with, I see my co-author Charlie is in the audience. We have a paper coming out in December next month in the British Medical Journal, which was looking at why do people trust celebrities for health advice. When we see, and it's not in celebrities or former US vice presidents or former presidents or anyone who are clearly experts in one domain. Maybe models might be experts in fashion. Bill Clinton might be an expert in US foreign policy, but of course not experts in diet and things. And during pandemics, we often see celebrities weighing in on should they get the vaccine, should they not get the vaccine, will it cause things, will it not cause things? And we're hardwired to think these. Yeah.
No, absolutely we do, and it's challenging. One of the things that we talk about and actually pursue is identifying ahead of time, ahead of pandemics, spokesperson and champions, credible people within their communities. Now, again, they may not be celebrities. Some instances they are, that can then help deliver appropriate health messages and accurate information. But I think it's not just in the movie. It occurs in real life, as you all know. Yeah.
That's the scary part.
Yeah.
Great. Holger?
Thank you again, and thanks in particular for the what I would say for the advertisement for public health and the public health residency programs, perhaps, that are out there. One of them in our department, where we're always looking for good candidates. But I have a question that probably is at the interface of health policy and health, global health policy and global health research. Specifically referring to the opportunities that, as sad as it sounds, that exist during a global outbreak, the opportunities for research. And I'm specifically thinking of medications, and I'll come perhaps to personal protective equipment later, but medications that antivirals that have existed for a while, and for which there are still very, very important questions to be answered. And doing the H5N1 guidelines and doing later influenza guidelines with WHO, one of the issues that was raised was why wouldn't outbreaks be used for doing research, and why wouldn't there be preparedness? Which is one of the things that we called for with one of the guidelines, at least. Why wouldn't there be research preparedness on an international level, collaboration of public health agencies to do the trials when there is equipoise, trials on antivirals and trials on protective equipment, because they are not being done, and the opportunities such as H1N1, once again, it sounds sad to say it's an opportunity, but it is really a research opportunity. They are not used in the way that they should be used. And it is very clear to me, and then I'll stop with my first question, or comment perhaps. It is very clear to me that in many countries of the world, these opportunities cannot be capitalized on because of resource issues, but in many countries in the world, it could be capitalized on. And why? So why is that not happening? When I ask these leaders in influenza, anything that has to do with influenza, really, they couldn't give good answers. Yeah.
Yeah, no, thank you. That's another outstanding question, and I think you're absolutely correct. I think pandemics, outbreaks, offer unique opportunities for research to answer specific questions that you wouldn't be able to answer in other circumstances. You have to be careful not to just jump in and try to answer any question, but they do, and that's been recognized, and there's been some talk about a research agenda. Of course, it has to be done ethically within, with the appropriate institution review boards and etc. And there's been talk about developing those protocols and tools ahead of time for collaborative research. There's also consortia that have been looking at clinical trials, antiviral, etc., clinical research. I think it's very, very important. It's part of the planning for pandemics. What happens is what has happened in the past is that you jump into one and you're not ready to do that kind of research. But I think it's very, very important if it's done right, and it has to be done right. It has to be above board in terms of ethics of the populations, the vulnerable populations that you're dealing with affected. But there are answers that we couldn't get, and the research that can learn from it that you couldn't get otherwise.
Great. Right here in the front. Second row. Yeah.
Perfect, thank you. My name is Cam Galindo. I'm a first-year student social science here at McMaster, and I also work alongside Hamilton Public Health on a few initiatives that they run. I guess my question is, from a political perspective, Doctor, what would the best way or an ideal way for governments to work together during a pandemic be that global, federal, provincial, or municipal? What would the best way to deal with a pandemic be?
Thank you for the question. I think the best way to work together is to establish those relationships and work together before and outside, the pandemic. I think that is, whether it's governments or whether across sectors, I think you need to have done the work, gotten to understand the roles and responsibilities and how you're going to do it before an event for you to do it right during an event. And I think governments have come a long way, and I think those conversations and channels of collaborations exist. Yeah.
Thank you.
Great. We have a question in the front. Yep.
My name is Stephen Ma, and I'm a third-year life science student here. My question is, when there isn't a global outbreak, what type of conducted research is prioritized at, say, the Center for Disease Control, and what type of research do you think is most important for mitigating future pandemics?
So what type of research is prioritized at the CDC, and what's the most important for future pandemics?
Research to be conducted during pandemics, or
like, say, right now?
So during the inter-pandemic period, what research does the CDC do, and what are the top priorities?
Right. So at CDC, the research that we do is applied research to help improve interventions, to help improve strategies, for response. And so the type of research that occurs guided by analysis of gaps. And so, for instance, I mentioned personal protective equipment. There's some research that's being supported looking at that outside of, pandemic, and there are a whole range of areas where research, even guided by gap analysis and prioritization and resources when available, as available.
Certainly one of the things I've been hearing about as a top priority is looking at social mechanisms during a pandemic. When should schools be closed? When should schools not be closed? And there's actually school closing is apparently one of the most effective means of limiting a global, fast-spreading pandemic, given schools are often where this is where it's spread between people. If we think in our lives, how many people do we actually interact with very personally on a day-to-day basis? For me, I go to my office, I'm typing on my computer, I interact with many people virtually, and of course I see people, but not like what happens at a school.
Yeah, no, school closures have a role to play. Again, it depends on when you do it and what happens to the kids, where do they go, but yeah.
Of course, yeah. No, I don't mean to advocate for that, but it's interesting that there's increasing attention in research looking at, well, we have technologies that are, of course, essential, but what are social mechanisms that can be used? During H1N1, there was, in Canada, there was this phenomenon where people started to cough into their elbow instead of coughing into their hand, which I was told today was a very Canadian thing, and apparently you could spot who the Canadians were in international airports based on where people were coughing into, and so that was an interesting.
So we copied you. That's actually has become the recommendation of what to do is you cough in your elbow.
So that's those Canadians in the crowd, we can feel proud about that.
Yeah.
So I see we're almost running out of time, but I think we probably have time for maybe 2 more questions. Okay, one over here. Yep. Perfect.
Hi, Doctor. My name is Naima Kotadia, and I'm a 4th-year student in health sciences, and I'm also in Stephen's class at the moment, global health advocacy. And I just had a question relating to religious practices and how, especially in such a multicultural country like Canada, like how would you be able to regulate how those practices occur, or if there's some sort of communal practice that commonly occurs, how would you be able to regulate that during a pandemic, and what are the measures that can be put in place to kind of not impose on religious practices, but and still be respectful, but kind of limit the spread of the pandemic?
So how can we protect religious freedoms while also ensuring a good response?
Thanks. You guys have great questions. Another outstanding question. I think engagement in community leaders and figuring out the best ways to address religious practices and with the knowledge of outbreak and transmission modes and how you can't regulate these things, or if you try to regulate them, you don't succeed. But if you have buy-in from leaders in terms of how beneficial changing some practices, how beneficial it is in the context of a pandemic, to the community, I think you have a better chance of succeeding.
Great. And then the final question.
Thank you very much. My name is Gagan Dhaliwal. I'm a second-year medical student here at McMaster. My question is relating to sort of the next, 10 to 20 years. As everyone knows, there was recently a government shutdown. There was a recession 5 to 6 years ago. These have been very sort of economically tumultuous times. And in these times, virtually, whether it's Canada, United States, Europe, governments are finding a way to save money. They're trying to tackle a debt crisis. Unemployment's on the rise. So there's a lot of economic problems beyond healthcare and public health. But because public health is sort of a domain of the government, sometimes public health may take a hit, or there may be situations where money is diverted from public health to another resource. So my question is related to, in the next 10 to 20 years, given the economic environment, the tumultuous political environment, what do you think are the consequences for public health, and what's sort of your biggest fear or concern going forward?
So what are the greatest consequences of recent economic ups and downs for public health in the future? And of course, in terms of Canada, the Public Health Agency of Canada used to have 3,000 staff, and budget cuts. Now the staff's only 2,500, so 500 staff were cut. So it's very relevant in Canada.
Yeah, and it's relevant to the U.S. We've had budget cuts repeatedly, and our budget is, at CDC is the lowest it's been since 2003, and so it is challenging times. It's, I'll tell you the types of things that we talk about at CDC and that are relevant is makes it how more so important to be able to document and communicate the return on investment of public health. What is it that we do? What is it that society gets or doesn't get if public health went away? And so, we haven't done that well in public health, but I think it's the more important that we do that, and document and show what goes away if you are not able to do what you do. So yeah, that's just one answer. The other thing, and I'm, shrinking resources forces one to think more critically at what you do, and there are definitely efficiencies that one gains by being forced to look at one's systems and do things differently, and we've done that, but again, after you've done that a little bit, it becomes okay, you've gained all the efficiencies, and so what is going to get lost by shrinking resources below a level that you can sustain? And then there's also prioritization. Would you let go? You can't do it all. So thanks. Another outstanding question. Thanks so much. This has been...
Yeah, thank you everyone for coming. Yeah. Thank you very much, Dr. Kabaz, for joining us.
You.
This is really quite a pleasure. Great. So watch out for future events from the McMaster Health Forum. There's always new public events happening. And otherwise, have a wonderful evening. Thank you very much again for being here. Thank you.
Thanks.